Dear chairs, supervisors, and colleagues, welcome to the 15-month progress report. For the next 10 minutes, I'm going to present my progress. I've got 3 projects about gastrointestinal bleeding, and if I want to put one title for all the projects, that would be the pre-endoscopic assessment and post-endoscopic care for patients with gastrointestinal bleeding. I'm Mahmoud Obeidat. I'm a medical doctor and PhD student at the Center for Translational Medicine. On the slide, you can see my supportive team. My vision is to improve care and outcomes for gastrointestinal bleeding patients and to be involved in the guideline-based treatment for those. And my mission would be to prove the high proportion of hemodynamic instability among those patients and the variability in the different treatment methods. These are my specific goals. I'm working on 3 main projects now. The first one is basically about the proportion of hemodynamic instability in upper GI in all sources of gastrointestinal bleeding, and the second one about the pre-endoscopic assessment for those patients, and the third project is comparing early versus delayed enteral nutrition for upper gastrointestinal bleeders. Now I'm going to talk about my first project in detail. As you can see in the title, 1 in 4 patients with gastrointestinal bleeding develops shock or hemodynamic instability. But before we ended up with this conclusion, there was a very long journey behind that. We know that the incidence of GI bleeding is unacceptably increasing, with a mortality rate up to 10% and has not been considerably improved in the last 50 years. And data from several studies showed that hemodynamic instability is associated with untoward outcomes like mortality and rebleeding risk, pre-hospital transfusion, and sedation complications, especially if the patients present with a massive bleeding. And there was a recent big study from 2019 showed that gastrointestinal bleeders with shock are at 10 times higher risk for hospital mortality than without shock. So the aim of this study to assess the exact proportion of hemodynamic instability and shock among all gastrointestinal bleeding sources. So we use the COCOPOP framework for our clinical questions. The condition is hemodynamic instability and or shock. The context is gastrointestinal bleedings among adult patients. We've done the systematic search on 14th of October last year using the search key containing 2 main domains. The first domain, gastrointestinal bleeding with different synonyms, and the second domain, basically the shock and hemodynamic instability. This is a selection flow chart of the article selection process. We've managed to choose 220 studies out of 11,000 hits, and those 220 was eligible for data extraction. A brief orientation how to look at my slides. On the left side, you can see the gastrointestinal bleeding source, and in this case, unspecified sources. So it includes upper and lower GI bleeding. And then our first plots contains 2 subgroups. First one, whether the patients developed shock or hemodynamic instability. And number 2 is whether they developed it on admission or during hospital stay. So in this case, in all gastrointestinal bleeding sources, we've got 25%. That means 1 in 4 gastrointestinal bleeding patients develop shock or hemodynamic instability. And this is the title of our manuscript. Next to the plot, you can see the certainty of evidence. In non-variceal bleeding, we have 22%. In variceal bleeding, we have 25%. And in colonic divertical bleeding, we have 12%. And all these studies were assessed on admission. So in conclusion, we have 1 in 4 in all gastrointestinal bleeding, 1 in 5 in non-variceal, 1 in 4 in variceal, and 1 in 8 in colonic divertical bleeders developed shock or hemodynamic instability on admission or during hospital stay. The strengths of our project that this is the first comprehensive overview about hemodynamic instability and GI bleeding based on the bleeding source, subgroup analysis, and the large number of included studies also provided a more precise data. Of course, we have some limitations. The definition of hemodynamic instability and shock is not the same among the included studies, and we actually lack this definition in 1/3 of the studies. And we mostly included retrospective observational studies. As implication for practice, this is a very important project to to prove the high proportion of hemodynamic instability. So it is a chance to increase insight and awareness for hemodynamic instability and shock in GI bleeding. Those patients need continuous monitoring and rapid correction of hemodynamics. And of course, healthcare providers must carefully pre-endoscopically assess those patients and a strong adherence to risk stratification scores. For research, we want to standardize the definition of hemodynamic instability and maybe establish a protocol to proactively recognize and monitor those patients in the routine management. This is the current status of my manuscript. It is now under review in the Clinical and Translational Gastroenterology Journal. Before I go deep into my second project, I would like to use my first project as an introduction for this. This is going to be an international survey about the pre-endoscopic assessment and management for hemodynamically unstable patients. And I would like to highlight here that we recognize some gaps and uncertainties in the most recent update in the ESG guideline. So the aim of this study to better understand the care, assessment, and management for those patients. So our hypothesis is there is a significant variability or heterogeneity between the different treatment methods. And we've established this questionnaire divided into 3 main sections. And now I'm going to talk about each section in detail. The first section is about demographics and clinical practice for the doctors and hospitals who are going to participate with us. And we are including questions in the geographic region, how many years they have been in a practice, the focus of their specialty, but most importantly, whether the hospitals provide 24 hours gastroenterology care, out-of-hours endoscopy, interventional radiology, or surgery if needed. In the second project, in the second section, the definition of hemodynamic instability. After we've done the first meta-analysis, we realized that the authors define hemodynamic instability differently. But the most common definition was number 3 on the slide, the systolic blood pressure less than 100 and heart rate more than 100. But also other authors included syncope, orthostatic hypotension, and any signs of organ hypoperfusion. In the third main section, we are asking some questions about the pre-endoscopic assessment, and we are asking whether they adhere to any risk stratification scores, what type of fluid they are using, and the rate of fluid resuscitation. Also asking about if they use prokinetics or antibiotics, intravenous PPI before endoscopy, and also the optimal time for endoscopy for variceal and non-variceal bleeders. Quick update about the survey. We already had a meeting and agreement with the first author of the ESG guideline, Professor Ian Grarnick, and he's going to assist us to circulate the survey among the society members. Also with Dr. Jolt Bognar, who's a chair at the European Emergency Medicine Society, also going to assist us to circulate it among the society members. This is a flow chart of the survey, and we're going to use the red cap for the online distribution. For my third project, it is going to be a meta-analysis of randomized controlled trials. We are comparing early and delayed enteral nutrition after upper gastrointestinal hemostasis. We know that upper GI bleeding is the most common cause of endoscopy. And we know that enteral feeding is usually delayed to 72, sometimes to 96 hours after hemostasis, due to the fear of free bleeding, despite the lack of evidence. And several RCTs showed that early nutrition had no significant effect on treatment outcome, actually. So the aim of this study is to evaluate the safety and outcomes of these 2 interventions. We've used the PICO framework for that. The population is upper GI bleeders, variceal and non-variceal. Interventions is early enteral nutrition, comparing to delayed enteral nutrition, and the outcomes is mortality, rebleeding, length of hospital stay, and blood transfusion. And our hypothesis is that early nutrition does not increase the risk of complications after upper GI bleeding comparing to delayed nutrition. Our implication is to improve care for upper GI bleeders after endoscopy and based on the bleeding severity. We've done the systematic search on 10th of November using the following search key. We've managed to select 11 randomized controlled trials, and this is a preliminary results. This is for the outcome of early rebleeding less than 7 days. We do not have a significant result. As you can see, the confidence interval touches the line of no effect, and the risk ratio is 1.06, which means no significant. And I must say here, like having no non-significant result is indeed a significant result. Early refeeding does not increase the risk of 7-day rebleeding compared to delayed refeeding. Neither on 30-day mortality. Early refeeding does not increase the risk for that as well. As a summary, this is a slide of my project with the planned submission date. And before I close my presentation, I leave you with this quote from Isaac Newton. What we know is a drop, what we don't know is an ocean. I thank you for your attention, and I am happy to receive and answer your questions.
Brilliant. Congratulations. It was brilliant, just like every time. So I would like to ask you about the third project. How do you define enteral nutrition? Because in my practice, usually we give anything to eat or drink for patients, but usually we start with fluid, and usually with nutrition drinks, because we've got some situations where the rebleeding was exactly because some solid foods, and that's why I'm interested in how do they define actually enteral nutrition.
Excellent questions. I'm glad you asked this question. So unfortunately, we only have 11 studies regarding this topic. If I want to answer your question, we have to investigate 5 main aspects, actually. First one, the source of bleeding. For example, non-variceal comparing to variceal. Second, the severity of bleeding. And third point is the enteral nutrition. It includes oral nutrition or tube nutrition. 4 is the dietary nutrition. So what do they actually give the patient? Some studies use like fruit juice or rice in a liquid form or soybean juice or milk. So this is also a limitation for these studies. 5th point is the definition of early and delayed refeeding. Among the studies, it was not exactly the same. Some of the studies define early refeeding within 6 hours, some others within 12 hours. Other studies within the first 24 hours. And delayed refeeding, sometimes 1 day, 2 days, 3 days, even 4 days. So this is also a very big room for improvement in this project. But unfortunately, as I mentioned, we only have 11 studies. And obviously, it's not sufficient to cover all the subgroups in this project.
Just following up on that, you kind of answered the question, but I know it's 11 studies, but you can't mix the 6 hours with the 1 day being delayed. Like, what will you make a cutoff? And
24 hours.
Okay.
So most of the early refeeding is within the first 24 hours. So this is, we can put them together, and more than 24 hours for the delayed refeeding.
Thank you.
Yeah. Sure.
Mahmoud, in your first project, you said that you looked at hemodynamic instability during hospitalization. Of course, you looked at prevalence, but in the articles, are there reported any risk factors for these patients? What brings them to a higher risk?
That's also a good question. The aim of that study was to assess the proportion regardless the severity of bleeding, let's say. But if you look at the plots and if you look at the highest proportion of the study reported, like the highest proportion of hemodynamic instability or shock, I looked at the articles. Mostly the population is elderly population, more than 60, or they are presented with severe bleeding, like very severe bleeding, or they are indicated for embolization. So these were the 3 main, let's say, reasons why the proportion of hemodynamic instability was higher in this population.
Thank you.